So the next speaker I'd like to invite to speak is Dr. Indranil. So Dr. Indranil is a health economist and associate professor at the Jindal School of Government and Public Policy with an interest in health systems, development economics, political economy, and global health. He has 15 years of research and teaching experience in health economics and healthcare financing. He's a member of the World Health Organization, um, member of the World Health Organization expert group of national health accounts in Asia and the Pacific region.
Thank you, Professor Kumaran. It has been a great pleasure. Thanks the DPF for asking me, allowing me to be here amidst this very wonderful, distinguished panel. It was a pleasure hearing all of you, learning a lot about what Tamil Nadu has done and what other parts of the world has done. Dr. Ezelan, and then Dr. Arvindan, Dr. Dhanapal, Dr. Kumaran. It was a pleasure listening to you all. What I'm going to say, and being the last speaker, I'm a bit conscious because it has been a long, I think, very enriching conversation. So I would, am I audible and are my slides visible? I have few slides to show because some of the arguments many of you have made, probably I'm going to repeat those with some bit of data. That is the advantage of being at the end. So I'll probably save on some time there. So first of all, I'm going to highlight the inequalities that have been created in this period of pandemic with some numbers. I'm also going to talk about the one of the ways to address these inequalities, that is through building a public resilient health system through sustained public investment on health, and also not only putting more money, but how the health system should be more decentralized in a substantive way. And we have, let me try to make it full screen. So I think many of my previous speakers have mentioned that, if we compare the pandemic, the influenza pandemic, which took place 100 years back, we probably have much lesser number of deaths, particularly in our subcontinent. We were the biggest contributors of deaths, though death numbers in US or UK haven't reduced that much. We have been able to reduce them significantly. But at the same time, we must also acknowledge that in our subcontinent, there is huge undercounting of death. We have talked about the data gap in our country, in our subcontinent. So our death numbers are, would be much more than what we official estimates suggest, but nevertheless, there were lesser deaths in this. But at the same time, what we have seen, like many of my previous speakers have alluded to, is the effect of the lockdown on poverty, inequalities, and hunger. In our country, in the post-lockdown period, 400 million people have been pushed to poverty. This is more than population of any other country apart from India and China. Such huge and unprecedented crisis in modern times. And during this period, the gap between poor and rich have really increased. If we look at the inequalities, you'll see that both in consumption and rural income, the Gini coefficient has increased in this period of time. So people are really, and the effect on hunger, the long-term implication on the lives of children, women, and every citizen are yet to come out. So it's a huge crisis that the lockdown had built in. At the same time, we need to also recognize that this was also a time where there was unprecedented consolidation of wealth and income. If you look at, say, the top figure, you'll see that profits of the biggest companies of the country have gone to unprecedented level. in the last 15, 16 years. So much profit has not been accumulated. If we look at the global accumulation of wealth, now the top 10% has more than 3/4 of the world's wealth. And the bottom 10% have only 2% of wealth with them. But at the same time, the richer sections of the world also are the major contributors. The top 10% contribute to almost half of global carbon footprints. We need to take the inequalities that are very seriously and bring in distributed. I think Dr. Kumaran has very eloquently talked about the vaccine inequalities across the developed and developing countries. If you look at, say, he gave numbers about Africa and compared with Canada and UK. If we take out the excess vaccines that are available with US and Canada, that can meet the entire vaccination needs of adult Africa. So we need to redistribute. There is a lot of need for redistribution. And one of the major ways through which inequalities get created in the world is through public investment. Public investments are a major source of redistribution of inequities, public investment on health. But then we see that there is huge gap in public spending between high-income countries and low-income countries. High-income countries spend around $2,200 on an average, the median, whereas low-income countries are spending only $22. So 100 times more money is being spent. Take the example of USA. It has 4% of global population, but it spends around 35% of total public investment. And a lot of this public investment goes into sustaining the profit of insurance industry, commercialized healthcare industry in US. Around 500 billion is paid to the various insurance related charges. If we take this money out and give it to 150 countries around the world, their public spending would simply double. So this is, and I think there is a need to, at the global level, redistribute resources, channelize some of these resources through the developmental aid, through United Nations institutions like WHO, to the global south, to the LMICs, to the low-income countries, and help them rebuild their health system. So there is a significant crisis in that. And here I bring in the Indian context. Many authors, speakers have spoken about this. Our public spending on health is much lower compared to other BRICS countries. Brazil, Russia, China, South Africa, they spend at least 4 to 5 times compared to India. We spend current health expenditure, if we take out capital, it is less than 1%. Clearly, the 2.5% being talked about by the central government is a myth. The latest national health accounts numbers show that our actual spending is much less. And Dr. Selvaraj was very right to point out that this is when we add water, sanitation, and other sectors to show this. And there is a clear relationship between how much government spends and how much people spend from their pocket. And India is one of the countries low public spending and very high dependence on out-of-pocket expenditure. We need to take concrete efforts to change this. And in this context, I'll bring the current budget. I'll skip some of these facts here. I'll skip some of this, but within the country also there exist huge inequalities. For instance, a state like Bihar spends less than 1/7 or 1/5 of what Himachal Pradesh does. Tamil Nadu, of course, does much better compared to many other states. And these inequalities get reflected in the capacity of the health system. For very simple examples, say if we take how many beds we have, government beds we have, we'll see that compared to other countries, India is at much lower level. This national is all public-private beds, but also within India there are huge inequalities. And I've been fortunate to work with Tamil Nadu government at various instances, and the brilliant work they are doing. Many other Indian states need to learn from the experience and bridge some of these inequalities in infrastructure, in human resources. I'll skip some of these, but just to illustrate that point that we have huge interstate variation. And the other important point is that in the period of pre-pandemic, we have seen that the country has already been in a slum, in a situation of demonetization and rural unemployment. Our hospitalization access had reduced. Across the board, we have lower hospitalization rate. This is a very alarming indicator indicating excess barrier to hospitalization care. And one of the reasons for this is huge increase in cost of hospitalization, particularly in the private sector. Many states have gone to the government-funded health insurance schemes, but in those schemes also, we see huge out-of-pocket expenditure incurred by people in the country. Now, how to change this? And one of them, like many my previous speakers have spoken, was to expand public spending on health, particularly by the union government and also the states. But in the middle of this pandemic, we see, my other speakers have also alluded to this point, that our real public spending on health by the union government has been cut. It is from 0.38% of GDP, it has gone down to 0.35. We need to keep in mind the major spending happens with the state governments. And this spending has huge consequences, cuts in spending has huge consequences on the lives of women, children. Because one of the successful schemes of the government, the National Health Mission, which has led to major improvements, saved millions of lives, improvement in maternal health, child health, vaccination, the budget of this scheme is being continuously curbed. There's a lot of euphoria that the National Mental Health Program has been expanded in this. There is a telemedicine introduced in the National Mental Health Program. You know, if we go beyond the euphoria and try to see the numbers, only 40 crore rupees is spent on the National Mental Health Program, which is 30 paisa per person per year. Dr. Kumaran, I can't say how much 30 paisa means in terms of cents. It would be so low. I am not in a position to calculate. But also look at we cut on the COVID budget also. Last 2 years, we had invested significant money. This has been cut to only 226 crore. Are we expecting that there is no further wave going to come? Are we so sure about it? We had a lackadaisical approach in the second wave, and we have faced millions of deaths during that period. The only scheme that has shown huge increase is the digital mission. We need digital access. We need to improve access to digital technologies. We need our health workers, health system to be empowered by digital system. But we also, the digital system can work only when there is a strong health system in place. And where you have the safety, security of individual data in place. We don't have such systems in place, and we are euphoric in the middle of pandemic to expand the digital. Well, I think this is a hugely problematic thing. We need to revisit this digital health mission significantly. And as a result, our investments on primary care, the health and wellness center, which is being hugely under invested, low on priority. There's so many other issues. My previous speakers have talked about the health workers. They were the frontline health workers, are the backbone through which entire success or whatever success we have had. But many of our frontline workers who are women do not even get paid proper wages. ASHA workers, We need fair wages, social security, decent working condition for them. The cuts in budget affect that. It's a significant concern. They should be rewarded, but we see that their allocations are being reduced. Public investment on research has been talked about. Only 3% of union budget is spent on medical research. And one of our premier research institution, ICMR budget, has been cut in the middle of the pandemic. This is really concerning. One of the, of course, positive thing is the allocation towards biosecurity preparedness and pandemic research, bringing in One Health into various research institutions. But then this cannot be at the cost of the research that Indian Council of Medical Research and the institutions, various sciences are doing in this period of time. We cannot do this. We have to also strengthen our systems of medicine production, medical equipment, and vaccine production. States like Tamil Nadu has a very interesting role model of medicine procurement and distribution system. We need to bring this back. We need more research. If we had better domestic production capacity, we could have done much better in terms of PPEs, in terms of vaccine equipments, in terms of testing reagents. So we need to strengthen this. And another crucial point, how much time, Dr. Kumaran, do I have? Another 2 minutes? Is it enough?
Yeah, sure. Yeah, sure.
Please finish the presentation. Okay, thank you. So the other crucial thing, and many previous authors have also spoken about it, we need greater transparency, openness, participation. We are an union of states. We are not a central versus state. We need to keep that approach in mind. There is a lot of centralization taking place. We need to decentralize, debureaucratize health system. Local bodies need to be empowered. A lot of preventive public health action in the country lies with the local self-governments. They spend very little on health because they don't have much resources. We need to devolve resources from states and union governments to these local bodies so that the preventive public health system can be strengthened. And in this period, we have also seen human rights violations. The National Human Rights Council had actually given advisories to states and union government. We need to respect the human rights issues. And gender aspects concerning health, the livelihoods crisis that women have faced, the gender-based violence that women have faced during this period of pandemic needs greater attention, need public investment. Unfortunately, the schemes related to this women health and social security have been cut. The last crucial point I want to bring in, there needs to be a coordination with public-private system, but unfortunately, our private sector is largely unregulated. They range from small providers to large corporate hospitals who are mostly in big metropolitan cities, but they're completely unregulated. We need to bring the private sector into some form of regulation where Clinical Establishment Act is implemented. There are regulations of fees. There is some curb in the irrational prescriptions. Many of my previous speakers have talked about the kind of black marketing that took place. If we had a better governance system, we could have really done better. Tamil Nadu is a model. Kerala has done very important things in terms of regulating rates. We need to emulate such fates in other parts of the country. So, and then there are these big public money going to private hospital for free care. We need to ensure that patients really get free care that they have been promised to. There is a lot of violation. Tamil Nadu, Kerala are doing better. Some other states are doing better, but we need, as a country, need to take a very different approach towards the for-profit private sector in order to bringing the sector into a system of, coordinated more holistic, solidarity-based care rather than a system driven by profit and vested interest. I'll close here. Thank you so much for giving me this opportunity. Thank you.
Thank you so much, Professor.
Yes, Indranil, Professor, thank you so much for your time. And I've heard a lot of things about your work through Archana. I think you were a professor too, and so maybe I would like to remain in contact with you. I'll get your contact details from her, and then I will probably shoot you a WhatsApp message or an email, whatever you prefer, and then we could stay in touch. And we also do a lot of Twitter Spaces, so you can also join on Twitter Spaces, and we can discuss one-on-one, which is more informal, but but we get a lot of spontaneous audience.
Definitely. I'm not so savvy on Twitter and social media in general, but yeah, we'll be communicating definitely through other.
Yeah. Okay. So I think with this, we have anyways overshot, and I think we can end our event. There were supposed to be Q&As, but I think the panel discussion itself crossed 90 minutes the event's time. So I think if they have any question answers, I think I will collect them and send emails to all the panelists, and then maybe we can reply in form of email, and then I can send across to those who asked the questions. So once again, thank you, Kumaran. Thank you, Indranil sir, and thanks to all other panelists for joining. Thank you so much.
Thank you, Kumaran. It was a pleasure meeting you and rest of the panelists. Yeah.
Thank you, everyone.
Let's keep.